quality in colonoscopy. So what's quality in colonoscopy? We already asked, we already talked about what is quality. If you ask any layperson or ask yourself or ask your patient, the patient will say quality means how good or bad something is. I mean, as simple as that. Why should we have good quality colonoscopy? We know colonoscopy is the gold standard test for investigation of the colon. As you know, the colon cancer is on the rise. And we also know that colonoscopy and polypectomy will reduce colon cancer by about 90%, which is fantastic. So when you're talking about quality in colonoscopy, various things come to your mind. First of all, as you've already heard, you need to think, is the scope actually needed? You have to look at the patient factors. What does the patient expect out of the colonoscopy? What about the endoscopist? What are his skills? The bowel preparation? Professor A already mentioned about adenoma detection rate. Zachariah mentioned about completion rate. And it's also important that you need to do a comfortable procedure for the patient, and also without any complications. And clearly, as you already heard, it is JAG, which is Joint Action Committee for Gastroenterology Endoscopy in the UK, and ESGE, which is heading the system of ensuring that quality is maintained. So from our point of view, when the patient comes for colonoscopy, all we see, I'm going to use this slide, see whether I can focus this. Is this focus? Okay. So the patient, from our point of view, this is when we get involved if you're a colonoscopist. But from the patient's point of view, it's a long way, it's a long path. Right from the time the referral is made, perhaps it's not yourself, but someone's made the referral. So it's a long process. It is important to ensure that it's clearly looked at. So we already mentioned about patient choice. Is that important? So this is very, very important that we do a pre-assessment. You need to find out if the scope is actually needed. Is it appropriate to be done? The various studies have looked at appropriate factors. In about 91% of the time, we get it right. So about 9% of the sometimes we actually scope inappropriately, perhaps not needed. So when the scope is not needed, what do we do? When the scope is actually needed, but the patient wants something else. We talked about patient choice, there are alternatives. We talked about CT colonoscopy. We talked about, there's also barium, which is becoming less done nowadays with the presence of CT colonoscopy and colon capsule. They all have a limitation, but they are good alternatives to give to your patient. So how good is CTC? CTC is pretty similar to a colonoscopy. This is obviously a landmark publication on Lancet. Professor Wendy Atkins looked at the sensitivity of CTC when compared to colonoscopy. It is pretty good. When you compare CTC with a colonoscopy for significant polyps, which polyps more than 10 millimeters and cancers, but all have everything else, they all have limitations. Speak to your patient, what they actually want. But it's also quite important to know that you need a good radiologist. Yes. So you have to talk to them and ensure that there is a clear pathway. We talked about NPIs, we talked about your carmine, endoscopy. They all only help if the bowel preparation is good. If the bowel prep is not good, your quality is not going to be good. So what is the choice of bowel prep? There's various choices. Do you do a split dosing or do you do the day before? So as in you give the bowel prep the day before the procedure, or you do it as a split, splitting it on one day and then another day so that they have dosing. What about low fiber diet? If you do low fiber diet, how long do you give it for? And this is a very important question that you need to think about is, what is the ideal interval between the last dose of the bowel prep and the time of the scope? So they have the last dose of the bowel prep and they come for the scope. what is the ideal interval? So clearly, the benefits of good preparation, we know there is higher polyp detection. Flat polyps like these are only seen if you have a good crown. If not, you're not going to see this. If you have a lot of stools sitting over this area, you won't see this. Obviously, gives you a very efficient procedure, and you don't need to repeat it immediately, so there's a lower need. We talked about split dosing as we give the bowel prep on 2 different days. Is there any benefit? Is it better compared to the day before? Clearly, this paper was published quite recently, just before this Congress, where it looks at the split dosing group, and the day before group was in red. The split dose group did very well compared to the day before in terms of adenoma detection, advanced adenoma detection, as well as sedated adenomas. We talked about sedated already. And so, giving a split dose, you pick up more sedated adenomas. The second paper looked at the quality of the prep when you compare splits versus the day before. You clearly see that the split dose did very well compared to the day before. And we've already talked about the right cloning visualization, which is not very good. You can see the split does very well when you're looking at the proximal colon when you come back to the day before. And we asked about the interval of the scope, the interval between the last dose of the prep versus the interval the last dose of the prep and the time of the scope. Does it really matter? If you look at this paper, which looks at the time of the interval between the dose and the colonoscopy, if it is less than 4 hours, and it compared to 7 to 8 hours, it did remarkably well. So the best time to scope your patient is around 4 hours of the last dose. What about the right colon? And the same paper looks at the compared between the less than 4 hours versus more than 7 hours to 8 hours. The right colon is seen much better. So your right time to scope the patient within 4 hours of the last dose. What about quality? Does it really matter about how ill the patient is, the comorbidities? This is one of our own papers, which is impressive. We presented the PhD. You can look at the quality of the prep is poor if they have a significant comorbidity. This is Charleston's comorbidity index. The higher is worse. When they are less comorbid, they do better. The completion rate is poor, the bowel prep is poor, and the bowel prep compliance. The patients do not manage to take the prep. So, colon superstar, we want to be giving a good quality procedure to our patients. We read about bowel door. What about the colon door? Would you have it scored by colonoscopists chosen randomly? Does it matter who takes the task? Professor Ray already mentioned about this. This is from Honorary, who is the czar of JAG, who talked about expert versus inexpert colonoscopists. An expert is somebody who completes the colonoscopy 95% of the time, but completion means to see the secret and very confidently document seeing that with a picture across, sees more polyps, completes polyp excision, misses cancer less, has less complication, and the patient usually are happy with the procedure. And this already mentioned about adenoma detection. Does it really matter? Yes, it does. The adenoma detection rate is a good predictor of interval cancer. Interval cancer is a cancer which is found in between 2 screening colonoscopies, which should not happen. And clearly, as you can see, the higher the adenoma detection rate, the lower the interval cancer. If someone has low adenoma detection rate, they have higher interval cancers. What about post-colonoscopy colorectal cancer? This is something new, which basically means that the patient we found to have a colon This paper looked at it, it was something like 9%. So which endoscopists are most likely to have higher miss rates, as in they are likely to have patients who have had cancers within 3 years? Someone who does not complete the colonoscopy, they don't go to the secret. Someone who has less polyps, and often it is a non-hospital setting, or it is being performed by a non-gastroenterologist or a non-surgeon. So we've already been talking about the right colon, which is the proximal colon. We know that the cancer, post-colonoscopy colorectal cancer, is much higher in the right side compared to the left side. Even in the UK, you can see that there's variation, remarkable variation in the post-colonoscopy colorectal cancers. So there is a strong four-fold difference across the nation in England. So what about the right colon? Why is the right colon cancer high? Is it because we do not actually complete the procedure? Or is it the withdrawal, as Khaled already mentioned about withdrawing, or we're not withdrawing properly? Withdrawal is taking the scope out from after you finish examining the secret and putting the scope out. Or is it poor prep on the right side, or is it different pathology? Professor Ray already mentioned how poor the colonoscopy completion rate was pre-JAG. And this study showed clearly by improving the completion rate can be improved by better planning the risk. You plan your patients better, very good training, and by improving bowel prep, you can increase the completion rate up and up and up. This is again, you can't talk about colonoscopy without mentioning Dr. Ray. He published about the paper and mentioned about image documentation, as in how we have to document our identity during colonoscopy, and this included 8 images of the colon plus a very good image of the secret must be taken. So if you're in Paris, you take a picture of yourself, in fact you take a selfie with the Eiffel Tower behind you. If you're in a secret, you're confident you take a picture with the secret, show the identity for well, and they're taking it all of us. Only then people will believe you. So we, as an endoscopy fellow, I did a project where I looked at the quality of the image documentation of the secret versus adenoma vegetation. And I can see that the endoscopists who do not take very good quality pictures of the secret versus those who took very good quality of the secret. And you can see that the adenoma, the polyp vegetation rate was much different. Those who take good pictures had higher polyp vegetation and higher polyp vegetation rate as well. So, meticulous colonoscopists detect more polyps. Withdrawal time, this paper was about a decade ago. We looked at 12 experienced colonoscopists and we compared colonoscopists who had withdrawal time of less than 6 minutes versus those who had more than 6 minutes withdrawal time. I found that the withdrawal time very clearly correlated with the adenoma detection rate. Nearly 16.5% difference between the two groups. Now, these are 12 experienced colonoscopists. They're very, very, very experienced colonoscopists. And you can see that the withdrawal time makes a high difference. Again, that was over a decade ago, and it's still good. Yes, it's still good. And this study was published fairly recently, where we looked at patients who were randomized for 3 minutes withdrawal time or 6 minutes withdrawal time, and the adenoma detection rate was found to be in this order, and they were each given an additional 6 minutes. So the 3 minutes ones were given 6 more minutes, so there was 9 minutes, and the 6 minutes were given 6 more, so there were 12 minutes. So as you can see, the withdrawal time doesn't matter. It does show you that you actually pick up more lesions. It's still good. We've already talked about serrated lesions. Serrated lesions are very, very difficult. They look almost very flat and more on the right side. They often have a mucus plug over it, and they're very easily missed. They're more common than right colon. They have a different pathogenesis to cancer. And detection is an important marker of quality. There is strong evidence that the withdrawal time, colonoscopy withdrawal time, does increase the detection, as shown in this paper. This was published 4 years ago, where you can see that those that had a mean withdrawal time of 9 minutes or more had a higher detection rate of serrated lesions, 8.7, whereas somebody who had 3 minutes had only 3.9 serrated. Perhaps we are missing cancers that way. So, I mean, we've had a strong discussion really about what is a good quality. So if you ask gastroenterologists, this is an American study, where they ask colonoscopists what they think is a really good quality indicator. They were asked to mark between completely agree and completely disagree. There was a strong agreement among the colonoscopists that completion rate is a good indicator, less so of an adenoma detection rate, and withdrawal time was probably not that much of a completely agreement. What about patients? Do patients know which is a quality indicator? They know about bowel prep. They know bowel prep is an important quality indicator. They do not know as much for adenoma detection rate or fecal intubation or withdrawal time. Maybe we should tell our patients, hey, my adenoma detection rate is so much. Come and get scored by myself. Fatigue factor. When you're tired, does it matter as an endoscopist? As you can clearly see, this is the adenoma detection rate versus the time of the scope. So if someone's being scoped at 8 o'clock or 12 o'clock, so you're finishing the list, your adenoma detection can drop. So bear in mind that we all humans, there is a strong possibility that you might miss adenoma. Your adenoma detection rate does fall down with time. Comfort during procedure. Comfort is very difficult to define, particularly if your patients having sedation, deep sedation, or having anesthesia. And again, it's difficult because patients, nurses, endoscopists mark it very rarely. What's important is still technique does make the procedure comfortable. We have started using carbon dioxide more and sedation, which does help. Sedation rates do vary, and nitrous oxide antibiotics doesn't work very well. I'm conscious of time and lunch is just between us, so I'll just quickly say that the majority of the patients do have a very good experience with just either conscious sedation or no sedation, and only a small percentage of them have quite bad experience where they have moderate discomfort to severe discomfort. I think I'll skip this because I'm aware that in Egypt you use more propofol and deep sedation, but in the UK we generally say the majority of them are done with no sedation or very less amount of sedation. Does sedation actually increase the completion rate? I'm not sure about that. As you can see clearly that this is the mean dose of midazolam, higher is more now. It does not actually increase. You can see that the lower the dose, they have higher cerebral intubation rate. It does not actually help. So what actually helps is a good technique. And so, in conclusion, Chairman, ladies and gentlemen, I'd like to say that split dosing improves the quality of prep. Split dosing also improves adenoma detection rate. Adenoma detection rate, withdrawal times are important markers of expert endoscopists. Pay more attention on the right side. Go back again if you're in doubt. See it twice. Be proud of what you see in the images. Thank you.